Good morning. We're going to get started. We're going to be using Nearpod today. The code's on the bottom, and I'll put it back up periodically when we transition to those slides. For those of you who don't know, my name is Todd Alter. I'm one of the PGY3 orthopedic surgery residents. Today, we're going to be talking about primary arthrodesis for complex tibial pilon fractures. Our objectives for today are to review the diagnosis and treatment options for tibial pilon fractures, explore the current indications for primary arthrodesis, and then discuss the current evidence base for the use of this treatment. Brief outline. We're going to start out with some introductory cases here. First patient is KW. He's a 48-year-old male who fell 10 feet from a ledge after being struck by a material drum and sustained an injury to his left ankle with an open wound. He works as a materials handler at a factory. His past medical history is significant only for idiopathic thrombocytopenia. On exam, he had a 5-centimeter wound over his distal fibula. His exam was otherwise neurovascularly intact. These are his initial x-rays when he came into the emergency department. He was taken for IND, an external fixator placement, and then a CT on postoperative day 1, showing significant articular comminution and widening, as well as impaction. So for each of these cases, I'll ask you what you think you would want to do for your treatment plan initially or definitively for this patient following his XFix, and then we'll revisit them later and talk about what we actually ended up doing. So if everyone goes on to Nearpod, it should show up for the first question. So it looks like most people for this one are saying they would start with ORIF. So we'll keep that in mind and we'll move on to the next case here. This is a 42-year-old male status post motorcycle collision who had a right lower extremity injury. He was taken for an emergent CTA that showed 3-vessel flow, also had a right elbow wound. He works as a longshoreman, no significant past medical history. However, on exam, he had a large wound on the anterolateral distal tibia that had gravel and dirt in it. There was gross instability at the fracture site, but he was otherwise neurovascularly intact. These are his initial x-rays when he came into the emergency department. He was taken for a right tibia IND and external fixator placement, and then returned to the OR on postoperative day 3 for his definitive treatment after a few INDs. So I'll pose again the same question. What would you guys do for this one? So for this one so far, we have a more mixed response, with some people saying ORAF, others saying X-fix with limited ORAF, and then others saying arthrodesis with a plate and screw construct. Next patient is a 56-year-old male BC who fell 6 feet from an attic with a closed left ankle injury. He's active, non-smoker, has diabetes that is well controlled. He does have a complex open wound and an extruded tibial plafond. He's otherwise neurovascularly intact. These are his initial x-rays. He was taken for a CT scan prior to his external fixator placement, showing severe impaction and widening at the articular surface. And 3D recons that help to better demonstrate that. He was then taken for that X-fix next day. So what are we thinking for this guy? Try that. So here, most people saying ORF still. One person said tibiotalar, tibiotalar calcaneal nail, and one said plate and screw arthrodesis. And one more here before we get into the meat of the talk. This patient NP, 49-year-old male who fell from an attic and sustained multiple right lower extremity injuries. Very poorly controlled diabetic with a prior tibia and fibula fracture that developed a synostosis. He has a complex open wound and extruded tibial plafond, but is otherwise neurovascularly intact. This is him, initial x-rays, and then in the OR with the majority of his plafons on the OR table. He also had a closed right tibial plateau fracture. He was taken for an IND and X-fix of both injuries on day 1, and then taken for a CT. Severe bone loss there. So what do people think about this one? Again, a lot of love for the TTC nail here, and then a few for plate and screw arthrodesis. No one for ORAF. All right, so we'll revisit those later. Some brief background on tibial pilon fractures. The distal tibia was first described as a pilon 100 years ago by a French guy named Destow because it resembled the pilon to a pestle that the pharmacist would use. And it encompasses the distal aspect of the tibia and includes the articular surface, which widens distally to create a higher surface area at the ankle joint. There are a number of muscles and their respective tendons closely associated with the pilon, including the tibialis anterior, extensor hallucis longus, extensor digitorum longus in the anterior compartment, the peroneus tendons in the lateral, and the gastrosoleus complex, tibialis posterior, and flexor digitorum longus, and flexor hallucis longus posteriorly. Also in close proximity are a multitude of neurovascular structures, including the deep peroneal nerve and anterior tibial artery, the tibial nerve and posterior tibial artery, superficial peroneal nerve, saphenous nerve and vein, and the sural nerve. And applying static stability to the mortise are a number of ligaments, including the interosseous membrane, anterior and posterior tibiofibular ligaments, deltoid ligament, and then the fibular collateral ligament contributing to but not directly attaching to the pilon. Epidemiology, this is a relatively uncommon injury. However, their incidence in treatment has been slowly increasing as motor vehicle and motorcycle collision survival rates have increased. The typical patient population are people in their 30s and 40s, typically male, although they can occur in lower energy injuries in the elderly as well. They are typically high energy traumatic events, and as such, there are often many associated injuries, both orthopedic and non-orthopedic, with the concomitant fibular fracture or ipsilateral lower extremity injury being very common. In terms of pathophysiology, this is primarily an axial loading injury. The talus is typically driven into the tibial plafond. However, any small variations in foot position at the time of impact can result in a different array of fracture patterns and rotation. However, despite the variations that we see in the fracture pattern, there are 3 consonant fragments that have been described in a majority of injuries, along with the lateral malleolus if present. These are the Volkmann fragment, which is associated with the PITFL, the anterolateral or Chaput fragment associated with the AITFL, and the medial fragment associated with the deltoid ligament. And then if there's a isolated avulsion fracture from the lateral malleolus, this is referred to as a Wagstaff-Lefort fragment. In terms of imaging, standard ankle and tibia fibula, X-rays are warranted, as well as lumbar imaging for high energy injuries. Almost all of these patients will get a CT scan, and preferably post-operatively, as the ligamentotaxis allows for better visualization of the fracture fragments. The primary classification scheme used for these injuries is the Aota Classification for research purposes. This splits things into extra-articular, partial articular, and complete articular. However, this is not the most robust classification system, and there have been multiple other groups who have tried to make more prognostic systems since then. The Rudy Allgaier system adds the level of comminution to the classification. However, both of these first 2 classification schemes are based entirely off plain radiographs and do not perfectly describe the fracture patterns that we see. Furthermore, the inter-observer reliability has been found to only be moderate for these systems. A few years ago, Leonetti and Tagani devised a new classification system based on pre-fixation CT scan, where they split things based on the number of parts and found the reliability between observers to be much better, and that it was also prognostic in terms of the FAS scores seen with the different fracture types. However, this one has not been adopted widespread at this point. In terms of treatment, there are a lot of options. However, it's very uncommon for this to be conducive to treatment in a cast or brace. Firstly, because of the level of comminution and displacement of the fracture, as well as the skin issues that arise from these injuries. For this reason, it's generally reserved for non-displaced fractures or critically ill or non-ambulatory patients. Majority of them are treated initially with a spanning external fixator. This allows for an indirect reduction, maintains length, and allows for the soft tissues to heal while we await our final fixation. The X-Fix can be used as a definitive treatment, either in isolation or in conjunction with a limited ORAF in situations where the injury precludes definitive internal fixation. However, the longer it's left in place, the higher the risk of pin site infections and ankle stiffness. Alternatively, a circular frame or a Lizard frame can be used with high union rates, but also high rates of pin tract infections. More frequently, the X-Fix serves as a temporizing measure for a couple weeks, followed by ORIF. Prior studies have recommended having skin bridges of at least 7 centimeters between incisions, although there has been some newer research that's challenged this dogma. There are various approaches for ORIF with different risks, benefits associated with each. More recently, there has been more interest in primary arthrodesis for the most complex Pilon fractures, which will be the primary focus of this talk. This has been used for people with complex injuries, severe soft tissue injuries, people who cannot tolerate multiple surgeries, and people who are manual laborers or maybe less reliable for follow-up. Proponents of this cite the poor outcomes of complex Pilon fractures and purported faster recovery with arthrodesis. There are a number of approaches that we will talk about for this as well. And then while this is not the focus of our talk, there are multiple salvage procedures for failed Pilon treatment that include a secondary arthrodesis or total ankle replacement. These injuries, unfortunately, are fraught with complications. These are challenging to manage. Majority of these patients will eventually go on to develop varying amounts of post-traumatic arthritis and ankle stiffness. And those who do undergo arthrodesis are more likely to develop adjacent joint arthritis, which we will discuss later. While the classification is based on fracture pattern, the soft tissue injuries in conjunction with these fractures are often equally or more severe and significant for the patient. As such, wound adhesions and infection are common complications despite our best efforts. There are a multitude of factors that affect the prognosis with these injuries. Anyone with less education, medical comorbidities, male gender, workers' compensation, low income, and increased fracture severity have all been shown to have worse outcomes. And one study even found that AO type C fractures have lower reported S short form 36 scores at 2-year follow-up than patients with pelvic fractures, AIDS, or acute myocardial infarction. So needless to say, these can be very severe and life-altering injuries. So let's get into our discussion of primary arthrodesis. We'll start off with a brief history to understand where we came from. I think it's important to know that arthrodesis of the tibio-talar joint was originally described in the late 1800s by Albert for use in pediatric patients with neuromuscular disorders, and then adopted early in the 1900s for correctional procedures in cases of poliomyelitis. However, the understanding of fusion principles and fracture management was not well developed at that point, and the non-union and infection rate was very high. However, in the 1950s, Charnley began to do a compression arthrodesis with an external fixator, which significantly improved the non-union rate, making it a more appealing option. During that approach, however, he sacrificed the anterior tibial artery and all of the anterior compartment tendons. And so over the ensuing few decades, there was a lot of work to improve on those methods using compression screws, plates, blade plates, external fixators that all built upon the principles that were described by AO and by Dr. Charnley. In the late 1980s, Johnson first introduced the concept of a TTC nail as a salvage procedure for patients with traumatic arthritis after ankle injuries or failed fusions. In the 90s, some surgeons began to implement arthroscopic approaches for arthrodesis. And during the same period, primary arthrodesis for non-reconstructible Pilon fractures began to gain some steam. Now, over the past 2 decades, those indications have began to expand, and we've had many improved surgical devices and techniques that have allowed for this to be a more successful procedure. In terms of indications, as more surgeons are performing primary arthrodesis, the indications continue to expand. However, it should be noted that there remains no absolute indications for this procedure. With that said, the primary indication is a non-reconstructible Pilon fracture. Those are ones with significant articular comminution that make anatomic reduction difficult or impossible, or severe bone loss. These generally fall into the AO type C3 category, although some B3 fractures may also be indicated. Another situation that would lead itself to primary arthrodesis is one that a patient has a delayed definitive treatment in which ORIF cannot be performed with an adequate reduction, limiting the ability to use that treatment. Similarly, any pre-existing comorbidities that put the patient at excessively high risk for complications of ORIF. Patients who have diabetes, schizophrenia, alcohol abuse who undergo ORIF have been reported to have much higher complication rates. And patients that get primary arthrodesis in this category allows increased time for soft tissue recovery and can be done with a more soft tissue friendly approach. One comorbidity that is particularly of interest is patients with peripheral neuropathy, as these patients lack protective sensation necessary to avoid overloading an ORIF construct. So with arthrodesis, articular reduction is not necessarily required, and you can avoid having extensive approaches and early weight bearing, which is ideal for these patients. And then also, speaking of which, the newer constructs with tibial-talocalcaneal nails have been considered as an alternative for patients who early weight bearing is necessary. Our most common construct that is used for primary arthrodesis is a plate and screws. This also includes blade plates. However, in addition to this strategy, tibial-talocalcaneal nails have also been used, as well as external fixators and ring fixators. For a plate and screw arthrodesis, is most frequently performed through an anterior approach between the tibialis anterior and EHL tendons. However, combined or posterior approaches can be used if the soft tissues dictate or if a blade plate is being used. It can also be achieved arthroscopically or in a mini open approach with a series of lag screws. The basic procedure, it involves debridement of any fracture callus and articular fragments, preparation of the tibial plafond and talar dome, and syndesmosis if it is present, and then packing any of the metaphyseal deficits. Plate and screw construct is then implanted with the ankle in neutral dorsiflexion, 5 to 10 degrees of external rotation, and 5 degrees of hindfoot valgus. Some surgeons will perform a lateral approach and excise the distal fibula to use it as autograft and reduce tension on the skin, though this decreases the surface area of fusion and eliminates the possibility for a future conversion to ankle arthroplasty. Postoperatively, these patients are generally immobilized for at least 8 weeks prior to partial weight bearing, and many physicians will order a CT around the 3-month mark to see whether fusion has been achieved. The primary advantage of this procedure being that you retain subtalar motion. For the tibio-talocalcaneal nail arthrodesis, you can, the primary advantage here is that you spare the soft tissues and you theoretically allow early weight bearing. The ideal patient is one who is low demand or likely to be non-compliant with weight bearing protocols, also neuropathic patients. This technique does require that the fracture doesn't propagate too far proximally in the shaft, and fusion rates may theoretically be slightly lower as it requires fusion of an additional joint, which also has been shown to lead to adjacent joint arthritis. In terms of preparing the joint, you could do it from any approach, although the posterior approach does allow for preparation of the ankle and subtalar joints simultaneously without the distal fibula resection. The Achilles tendon can either be retracted or split depending on the surgeon preference, and the joints are prepared in a similar fashion to the other methods. However, contrary to plate and screw arthrodesis, the subtalar joint is also prepared. The nail is inserted first by placing a guide wire through the calcaneal fat pad and reaming the shaft, and then interlock screws are placed in the tibia, talus, and calcaneus. Supplemental fixation can be added as needed. These patients can be made non-weight bearing, protected weight bearing as tolerated depending on the surgeon preference and patient characteristics, and then progressed until full weight bearing by 12 weeks. And there's been a push by some surgeons to get these people weight bearing much earlier. So at this point, I just want to take a second to see if any of the clinicians who are here feel that there's any additional indications that they would have that weren't listed, any preferred approaches, or if their post-op protocols differ significantly from what we've discussed so far.
Nothing from me.
I don't have a whole lot of experience with these, but that weight bearing issue is, from what limited experience I have, is super important. If you can get people to put weight across those things, it makes a massive difference. And that's one of the reasons why, the ring external fixator, when I was a resident, became really popular, because we could get people to bear weight right away. And we didn't have those nails so much. They were just coming out. But that seems to be the wave for these complicated ones, as that's important for bone healing.
Thank you. So before we get into the evidence specifically for fusions, I do want to speak a little bit about ORIF. So this is a 2019 study out of China that was the first to really look specifically at outcomes for AO type C3 Pilon fractures after stage ORIF that excluded any other fracture patterns. There were prior studies that reported on type C fractures, but very few specifically on C3. They had 25 fractures included. Average age was 24 years. 3 of them were open fractures. All were treated with an X-fix followed by ORIF around 2 weeks. They reported a 100% union rate, an average of 3 months, and the average AOFAS score was 81, which represented a good result. 15% of the patients had a malunion, and the complication rate was 38%. Despite the good outcomes seen in this study, there are significant limitations in its interpretation. First of all, there were very few open injuries. The patients were overall very young, and one patient did have a concomitant injury that limits their, which was a bilateral Pilon fracture. Additionally, it's hard to know how many of these injuries would go on to post-traumatic arthritis given the 2-year follow-up. For our patient population that we see, the average age is generally higher. There's more open injuries, more concomitant injuries. Additionally, there was a subset here who did have suboptimal AOFAS scores, which would likely represent the target population that we're looking at for our primary arthrodesis. This is a study from Leonetti and Tagani in 2017 that reviewed 71 Pilon fractures that they treated over a 4-year period. They were all evaluated based on the prior AO and Rudy-Algo classification system, and then they also devised their own classification system based on CT that we discussed earlier. The average age of these patients was 48 years. 21 of the fractures were open, 5 of which required a flap, and the vast majority of them were treated with ORIF. At their final follow-up at 3 years, they found that patients who had significant comminution at the articular surface, regardless of the classification scheme, had substantially worse complication profiles and AOFAS scores. And as such, this patient population probably more realistically matches the one that we take care of, and shows that in these specific fracture types, ORIF might have suboptimal midterm outcomes in the most severe Pilon fractures. So moving on to arthrodesis, the first one we'll look at is X-fix. This is a case series out of Germany that treated patients with comminuted Pilon fractures with severe bone loss and their soft tissue injury with a tibiotalar arthrodesis and a Lizarov frame. The authors felt that this would allow early weight bearing. simultaneously allowing distraction through the fracture site and then compression at the arthrodesis site. They utilized an anteromedial approach for arthrodesis and iliac crest bone graft. 3 of these 4 patients had bone defects in the distal tibia that led them to using the Oraf frame for a period of 9 to 12 months to allow for callus distraction. And then the 1 patient without significant bone loss was treated for a total of 13 weeks in the frame, which was then removed and transitioned to a cam boot. 1 patient developed an infection in their distal fibula, which resolved with plate removal and IND. And then only 1 patient who went on to non-union. He had a large soft tissue defect that required a free flap and did achieve union after reoperation. So while this technique showed moderate success in these severe injuries in these patients, the Alizarov immobilization for an entire year is likely not going to be effective for most of our patients. And it also immobilizes the forefoot for that entire period, leading to stiffness. Although they did report on union rate and complications, there was no additional outcome measures listed. So that is one of the less frequent methods used for arthrodesis. Plate and screw arthrodesis represents the most frequent treatment strategy. This is a retrospective case series from LA. It included 15 total Pilon fractures, half of which were open, and all of which were type C3 fractures. All but 2 of them were treated with X-fix and then definitive arthrodesis. However, despite calling this a primary arthrodesis for non-reconstructible Pilon fractures, the median time from injury to arthrodesis was 20 weeks, making it really more of a secondary arthrodesis. The authors used a posterior blade plate in these patients to avoid the wound complications that they found with anterior approaches and iliac crest bone grafting. They were made non-weight bearing for the first 6 weeks and then progressed to full weight bearing at 12 weeks. They reported a 100% union rate at 15 weeks, with most of these patients fully weight bearing by 12. And 1 patient developed a deep infection, and this was the patient who had a prior preoperative infection. Despite their excellent fusion results, this study did leave a lot to be desired. Despite these patients being described as primary fusions, they really were secondary and therefore have limited extrapolation to our topic here. The only outcomes they reported were union and infection, and it's also a small cohort and there's no control group. In the last decade, there was a retrospective multi-center case series from UT San Antonio, Pittsburgh, and Rochester that identified 20 AO C2 or 3 fractures treated with a posterior blade plate arthrodesis within the first month of injury. All these patients had INDs if necessary, an X-fix, and then delayed reconstruction and arthrodesis. They used a 95-degree blade plate inserted into the talar neck and iliac crest bone graft. Patients were non-weight bearing for 6 weeks, then progressively weight bearing from 6 to 12. Their short form 36 scores were obtained for an average of 7 years of post-op follow-up. This is composed of a few categories, including physical function, bodily pain, general health, social function, mental health, and a score of 100 represents the highest possible score. The patients in this series actually scored very low on the physical component with an average score of 31.2 and moderately on the mental component with an average of 51.6. However, all these patients were ambulating independently at final follow-up with only 3 requiring rocker bottom shoes. No infections or wound adhesions were noted. Complications included a DVT, a screw removal, a leg length discrepancy, and 5 patients subsequently developed subtalar arthritis. So overall, the study showed that a fusion through a posterior approach with the blade plate is reasonable for these injuries. However, the short form 36 scores were not impressive. It should be taken into account, though, that there's a non-specific scoring system that focuses on a patient's whole well-being and not just their single injury. And most of these patients do have concomitant injuries that could affect the score. It's also a small study group, no control. They did, however, include a comparison of the short form 36 scores to those from a similar study in patients undergoing ORIF, which seems to show that with ORIF, they have better scores in most categories although they argue that the comparison study also included type B fractures, so it isn't perfectly reflective of the patient population. This is a retrospective case series from Portland, Oregon. Their goals were to determine how long it takes to achieve fusion for primary arthrodesis, how the patient's outcomes end up, and if ankle alignment was maintained with early weight bearing with a ring external fixator applied. All of these patients had AOC3 fractures with at least 50% cartilage loss. All of them had INDs as necessary and a spanning X-fix. And then 10 of the ankles were approached with an anterior plate and screw construct. 9 of them were treated adjunctively with a ring external fixator for concomitant tibial shaft fractures. All but 1 of them was grafted with allograft only. The average time to fixate 15 days, and those treated with plates alone were made non-weight bearing for 12 weeks in a short leg cast. For those with the ring external fixator, they were allowed to weight bear as tolerated at 2 weeks. They followed these patients up for a minimum of 6 months, and all of them were fused by an average of 4.4 months. The average AOFAS score was 83, and the only patient who scored less than 80 had a severe open fracture treated in a ring external fixator alone for almost half a year. 1 patient developed a diaphyseal non-union that was resolved with revision grafting, and no revision surgeries were required for malunion. There was wound dehiscence, a PE, 2 hardware removals, and a superficial pin tract infection treated with antibiotics. So this study, while useful, was retrospective, small cohort, lack of control, and very variable injury characteristics and surgical technique. However, it does serve as a good proof of concept and shows that these patients can have pretty good functional outcomes with this treatment. More recently, there's been a push for more tibial-talocalcaneal nail arthrodesis for the reasons we discussed earlier. This is an interesting case report from Japan that utilized a TTC nail in 2 patients with type C3 Pilon fractures. Both of these patients had attempted suicide and sustained multiple coexisting injuries that delayed their definitive treatment after X-fix placement. For that reason, the surgeons decided to choose primary arthrodesis, as it would be impossible to obtain a reduction at their delayed presentation. They utilized a direct transfibular approach to the ankle, and the distal fibula is excised in all the cases to use autograft. For them, they used a TTC nail that was actually inserted antegrade via parapatellar approach at the knee, and then measured to end directly at the talus. The reason they did this was to avoid having to fuse the subtalar joint. And this arrow on the bottom of the screen shows that the subtalar joint is still intact. They felt that this was important. It would allow for early weight bearing without losing subtalar motion. These patients were followed for at least a year each. Both of them achieved union. Neither had any pain or assistive devices, and both had normal subtalar motion at follow-up at a year. There was no complications in either of them. So this study is obviously limited in its power, but it does present an interesting concept in that the TTC nail was inserted in such a way so as to retain subtalar motion, which is the primary disadvantage of this approach. So this could be also a good option in a patient who has an ipsilateral high tibia shaft fracture, where you can treat both of these issues at the same time. This is a report describing one specific use of a TTC nail for a primary arthrodesis of a complex Pilon fracture in a complex patient. This is a 58-year-old homeless female who jumped out of a 2nd-story window while fleeing an assailant high on cocaine. During her fall, she sustained a closed C3 Pilon fracture without any additional injury. However, she had a complicated history of seizures, stroke, and cocaine abuse. She was taken for a closed reduction and X-fix placement initially, and then for a TTC nail arthrodesis, as she felt that she would be unable to comply with any weight-bearing precautions or pin care in her living situation. She left the hospital AMA on post-op day 1 in a cam boot, and then showed up to the ER 2 weeks to get her Stützers out, and then again at 3 months for clinic follow-up. At that point, she had been weight-bearing as tolerated the entire time, without crutches, was walking 3 blocks without pain. Her AOFAS score was 69, and her x-rays showed consolidation of her fusion mass. She returned at 17 months, again with no pain, wearing normal shoes, and her AOFAS score was 79. These are follow-up x-rays. And so while this is just one patient, it shows that the TTC arthrodesis can be an extremely advantageous option in patients with complex Pilon fractures who may be unreliable to be non-weight bearing or have multiple medical comorbidities, as you can allow these people to be lost to follow-up and they might show up 17 months later and be doing just fine. This is actually a rare prospective case series that came from Egypt. A group of 20 consecutive patients with highly comminuted Pilon fractures were treated with a TTC nail arthrodesis. They were all graded as type 3 in the Rudy-Allgaier system with at least 50% of the plafond impacted. However, they had strict exclusion criteria that included no open fractures, no medical comorbidities, no vascular disease, essentially limiting the study to just healthy patients with non-reconstructible Pilons. All of these patients were treated initially in a splint for 2 weeks and then taken for a direct transfibular approach with distal fibula excision and autografting, followed by TTC nailing for retrograde. At final follow-up, they reported a 100% union rate and an average AOFAS score of 85, with the majority of point loss being due solely to loss of ankle and subtalar motion. They stated that all of the patients reported no pain, a plantigrade foot, and more normal shoes, and 2 of them developed malunions that didn't require secondary procedures. So this study is one of the only prospective studies in our patient population, and it shows that they can do very well in the first few years following these procedures. However, their strict exclusion criteria make it difficult to extrapolate this to our general population of Pilon fractures. And since there's no comparison group or long-term follow-up, it's hard to generalize this to everyone.
They had 100% union, but 2 non-unions.
100% union, 2 malunions.
Sorry, malunions, got
it. Finally, this is a systematic review that combined all of the evidence in the current literature for primary arthrodesis of these injuries. They want to synthesize a more complete understanding of the outcomes associated with treatment. However, the only studies that were included were retrospective case series, a case report, and an abstract. Nearly half of the fractures included were open fractures. The age range was from 17 to 81. And overall, they only found 3 non-unions and 1 infection reported. And almost 90% required no walking aid or specialized footwear. So while this was helpful to synthesize some of this data, the quality of the studies included was severely lacking. There was very limited information regarding the fracture characteristics. There was almost no objective data other than the union and infection rates. And it's really hard to imagine that in 109 patients, including almost 50 open fractures, that there was only 1 infection reported in the literature. So it's hard to take too much information out of this. In terms of long-term follow-up, it really does not exist in these primary arthrodesis patients. So any long-term results, you really have to base off of the post-traumatic arthrodeses and people who develop arthritis and primary arthrodesis, which is less than ideal. This, however, is a group of retrospectively analyzed 23 patients who had undergone an ankle arthrodesis for post-traumatic arthritis. About half of them underwent internal fixation, the other half external. They were able to bring these patients back for final follow-up at an average of 22 years, which is exceptional. Although it should be noted that there were an additional 41 patients who weren't available and were excluded, including 2 who had undergone a subsequent midfoot arthrodesis. All of these patients were found to have less subtalar motion than the contralateral side, with only 1 patient out of the 23 having more than 50% of their subtalar motion. The majority of them were ambulating without assistance. However, the patients reported significantly more activity limitation, foot pain, and disability on the operative side than the contralateral side. Despite this, almost all of them said they would undergo the procedure again. Radiographically, All of their unfused joints had more arthritis than the contralateral foot, especially the subtalar and talonavicular joints. And the authors found that the grade of arthritis did correlate moderately with the level of activity modification. So this study serves as the longest follow-up we have in patients who have ankle arthrodesis. And while these patients had this procedure as a salvage, it's the most similar to primary arthrodesis with long-term follow-up in the literature. And for that reason, it does provide valuable information that we can use to counsel these patients on what they should expect long-term. However, it's unclear exactly how much of the patient's disability stems from the arthrodesis itself and how much is from the adjacent joint arthritis that they develop. Additionally, almost all of them had substantially decreased subtalar motion despite having a preserved subtalar joint. So it's not entirely clear how much you gain by leaving the subtalar joint unfused. Unfortunately, there's no real comparison group here to see how similar patients would have done if treated differently. So let's go back to our cases now. As a reminder, this is KW. This was his injury. This was his initial treatment and his postoperative CT after the X-fix placement. So I'm going to give everyone another opportunity to say how they would treat this. You go back on Nearpod and we'll review, see if anyone has differing opinions than earlier. All right, so the vast majority here are saying ORF, which is what we did. They underwent a removal of the X-fix and ORF at 2 weeks. There was severe comminution and impaction, but overall a pretty good reduction. At 6 months, was walking with a cane, going to PT, wearing a lace-up brace, and had 5 degrees of dorsiflexion and 30 degrees of plantar flexion. At 1 year, they obtained X-rays in the emergency department due to increased pain after a routine PT visit that showed fracture healing with some arthrosis in the tibiotalar joint. And a CT was also obtained at this time, which happens to show us the fracture healing with significant arthrosis of the tibiotalar joint. The patient was seen in the office and taken for removal of hardware due to painful prominence. 3 months after the removal of hardware, 18 months since the injury, he's walking with a cane still and limping. His incisions are well healed and the pain from the hardware is resolved. He does still have a 40-degree dorsi and plantar flexion arc, but this is a guy who works as a longshoreman and still remains out of work. So the question being here, if it's going to put you out for 18 months to retain this much motion, is it worth it? Which is a question I think is still difficult to answer.
No, the question is whether he's ever going to go back to work.
That's also a question, yes.
Well, what about the question of whether you should have just left it in the X-fix versus opening it up? If the results are the same, why don't you not do a procedure? I mean, I don't know. Are there long-term studies?
Well, so that's the issue, is that there still is not long-term studies comparing that in these people with the most severe injuries, as it's largely based on these retrospective series and extrapolating data from other case series and reports from other injuries or secondary procedures. So, I think for this case, it's kind of dealer's choice, and it's hard to say whether he would have done better with one versus the other. There's obvious advantages and disadvantages.
Right, but we know from previous studies on other joints that a primary fusion always does better than a revision, or a primary arthroplasty always does better than a revision. Is it worth letting people see what happens? And versus just do a primary fusion?
Yeah, so I think there's been a large push for that recently, and is really why I wanted to bring this topic up today, is because people were going on to secondary fusion, and there's been a larger push recently to identify these patients preoperatively to see if we can get them, if fusing them earlier will get them better results. So I think that's definitely a reasonable comment.
Is there anybody that's done a comparison on a primary fusion versus doing nothing but an X-fix and seeing that need of fusion and then going on and fusing it later as a primary delayed fusion?
No, there's not, which is one of the biggest issues with what we're seeing with these injuries and the treatment, is that we're really lacking on comparative studies. And there's really a lot of room for growth in that area. So moving to our second patient, this is the one who works as a longshoreman, was in a motorcycle injury with the gravel and dirt in his wound. He had this open Pilon fracture, also the calcaneus, lateral cuneiform, and a tarsal fracture. It's placed into this X-fix, taken for multiple INDs, and then his definitive treatment. So what are we thinking here?
Does this thing let you show your poll results, or you can only you're seeing them?
I can see the poll results, and I think that I can share them with you afterwards. So I'll try that on this one. Yes, yeah, good point. You're the only one who can't see them. So we have kind of a mix here so far. Some people saying X-fix with limited ORF, some saying ORF, some saying TTC nail. So here's what we ended up doing. During the operation, a majority of the distal tibia was found to be non-viable and had to be resected, except for the posterior malleolus fragment. It was then taken for a anterior arthrodesis with a plate and screw construct, as well as antibiotic cement. Post-operatively, went for another CT. Showing the severe bone loss. Post-operatively, he underwent a free flap with the plastics team. At 3 months, he was taken back to the operating room to do iliac crest autograft to rise the arthrodesis with a posterior plate, as well as a plating of the lateral malleolus. At 9 months, he was partial weight-bearing crutches, but there was already evidence of hardware failure posteriorly and signs of a hypertrophic non-union. At 13 months, it got worse. And then at 16 months, was taken back to the operating room for a revision of the hardware and autografting of the injury site, of the arthrodesis site. And at this point, we do not yet know if this patient will heal. So based on what we've seen here, anyone have any different opinions about what should have been done?
I'm going to ask you, did you do all that to try to preserve subtalar motion? Was that your goal? I mean, why not as opposed to the nail?
Yeah, so partially because of the because of where the wounds were, they went with this approach, partially because I guess they wanted to retain motion, but unfortunately I wasn't there for the initial procedure. So I think that in hindsight, looking back at our initial, post-operative x-rays, we have a very large gap there to heal across. And maybe a TTC nail would have been more reliable to get compression across the site there. And also for the first few months, the patient only had the anterior plate, which pretty much was a load-bearing device because there's no contact between the cortices. So it was bound to have a lot of motion there. I think, this patient also had dirt and gravel in their wounds. They were really a complication waiting to happen.
So why wouldn't someone just leave that X-fix on? You have a horribly dirty wound. What was wrong in the past with an X-fix and letting the fracture heal? And then a year later or 2 years or whenever the arthritis settles into the delayed fusion, was that horribly unsuccessful?
Do you think that would heal?
I don't know. Go back to
the original films with the bone loss. You put an X-fix on that. That's literally never going to heal. I mean, that after they went back the second time, go to your plate films. I mean, look at all the bone that's missing. That's not healing.
I know, but they went in and took it all out and replaced it with cement. That's never going to heal. Now you're asking a plate to span that big gap and fuse a joint in light of a terribly open, dirty wound.
So another option, which one of the studies did prior, would be to put an Alizarov frame on, create a more proximal fracture in the tibia to allow for callus extraction there, and then compress at the fracture site with what bone you have left. But then you're in an Alizarov frame for a year.
But it works. I mean, one of the earliest cases Mark Butler did here when he came back from shock trauma was exactly that. Somebody got transferred in from JFK, and I happened to be on call. Opened up the dressing and basically took the person's distal tibia out of the wound in the emergency room. I was like, okay, now what do we do? And that's exactly what we did. Put an Alizarov on. Person had lost about 6 inches of bone, and he did a proximal fracture, docked the distal tibia onto the talus, and then fused it. And the guy did, it was a long process, but he didn't end up with a BK, and he had, only basically 2 operations.
Yeah, I think you have to have a patient that's able to tolerate that. It was, then wanted an initial stabilization and to go back and regraft it. That was part of the initial plan, and to add more fixation once the free flap healed.
I think everyone's just gotten, more. There was a time when Alizarov caught on and people were doing it regularly. And I think bone transport has just kind of fallen out of favor for these, one stage, theoretically one stage like a mascale. We're just going to put a mascale and take it out, and bone graft it, and it'll heal. I probably have to, some people have to keep the bone transport technique in their back pocket because it's going to be needed there's some cases where this is a disaster.
Yeah, I think that might be this case.
Yeah.
And then, if you do a TTC nail and you compress, then you're shortening the tibia, and, there's disadvantages to those strategies.
I mean, Alizarov can be used to treat osteomyelitis. Just the concept of bone transport can increase blood flow. And I mean, there's been cases of treating osteomyelitis without antibiotics with an Alizarov. So, it is there's newer ways to do it, with all these computer stuff, but I think you have to have Alizarov as an option.
Yeah, and I want to make a comment about, you mentioned you need to have the right patient. Patients are very resilient, and they tolerate the X-fix better than you think.
I've personally never seen an Alizarov frame in real life, so.
Well, it's been replaced mostly by the Taylor spatial frame, but
right.
And they're fairly similar. And it's, I kind of wish we did more of them, because you really need to see that as you go through this program.
So if anyone's listening, do more of those. Moving on to our third patient. As a reminder, this is our 56-year-old who fell from the attic with a closed injury, well-controlled diabetic. Had this it was a complex open wound. It was not closed. The plafond was extruding. This was their very impressive CT scan showing how much bone loss and impaction they had. And them after their X-fix. So again, I pose the same question. Yeah, not sure what happened there. All right, so for this one, almost everyone's saying arthrodesis, either with a plate and screw construct or a TTC nail. So let's see what we did. We did not do that. The patient was taken for fixation of their posterior column and posterior medial corner of the plafond first, and then the remainder a week later. They did strongly consider primary arthrodesis, but this patient decided that he did not want to sacrifice motion so that he could get back onto the golf course. This is how he looked immediately post-operatively. I think pretty good for what was there. And then at 8 months, he did have a delayed wound healing, but they did all heal without any additional intervention. He had no pain at this point and was walking with a rocker bottom shoe. However, at a year, he was found to be interning in his left ankle. He had a varus malunion. So he had to go, he was indicated for revision surgery at that point. It was discussed whether he should go for an arthrodesis at this point. And again, he elected to go against it and instead got an ankle removal of hardware, a distal tibial osteotomy, and a valgus calcaneal osteotomy. This is now 2 years ago at this point, and last year he played 83 rounds of golf. So, I guess you never know.
You have a lateral X-ray?
Not this last follow-up, no, for whatever reason.
The problem is you only have 3 years of follow-up?
So this is like a few months.
The guy played nearly 100 rounds of golf. That's amazing.
Yeah, I haven't played that much golf in 5 years. Holy crap.
So you can't play golf with an ankle fusion?
That's what I wanted to ask. Like,
that was my question to the surgeon who treated this was, can you play 83 rounds of golf with a fusion? And I don't know if there's a definitive answer to that question at this point.
So the biggest complaint of people with loss of subtalar motion is they can't walk on side hills or irregular surfaces. So it really would depend a little bit on the course. A real flat, boring course, probably not going to bother anybody with a fusion. But if you're walking over hill and dale, that makes a big difference.
Yeah.
And I was intrigued by that one case you showed where they put the the tibial nail in and just went from proximal and did not go through the calcaneus. How come more people, or was that just that one specific case, or is that something that people are now trying to go?
That was the only example I could find of that happening, where they did an antegrade nail for the fusion, and it was only in 2 patients. But I was also very intrigued by that study because a lot of these patients have concomitant ipsilateral tibial shaft fractures that maybe would be treated with an arthrodesis plus a plate and screw construct going up the whole tibia, or maybe you can just do an antegrade nail and get the whole thing in one shot.
I mean, even if they don't have that shaft fracture, it seems to me, based on what you've reviewed, that this loss of subtalar motion is such a bad thing.
Yeah, well, that's true. And that's also difficult because at final follow-up in people who had their subtalar joint spared, they still had very limited subtalar motion, even if it wasn't fused. So it's almost impossible at this point to say, like, how much subtalar motion are you really retaining and for how long?
That's a good point.
So it's challenging. I think that antegrade nail idea is a good one. I think the learning curve would probably be very high to get it placed perfectly into the talus from antegrade. And I think that not a lot of people are doing that in the US. That was from Egypt.
Did that have a plate? Was that just a nail, or was that a plate nail concept?
That study was just the nail. And they had a specially designed to nail with very distal interlock screws.
Of course. That's what I was thinking. I mean, I don't know, like Todd said, though, I mean, is that a long run for a short gain? Because since you're not retaining subtalar motion anyway, why bother?
Yeah.
Or does a subtalar joint become crap in 5 years and then you got to fuse it anyway?
Right.
That's why I don't do it.
All right,
although it's probably not totally analogous, it's always interesting that kids and teenagers who have a tarsal coalition and have virtually no subtalar motion, if you get them past their teenage years and they're, not having a lot of pain, we're not really doing much for these kids, and they become adults. And I would ask our adult foot and ankle colleagues how often they see these kids because of subsequent pain. And I haven't seen a lot of literature about that. So I think that they actually must accommodate for that. And maybe that's a little bit different because, if you have that as a teenager over many, many years, you probably, acclimate to that. And actually, there are people who develop what we call a little ball and socket ankle that most people believe is related to decreased subtalar motion. But those people do actually remarkably well also. So,
yeah, I think that's a good point. And it brings me to another point where that makes it very difficult to study these patients and compare them to people treated without arthrodesis, is that the AOFAS score has 14 points built into it just for tibiotalar and subtalar motion, which you lose 14 points off the bat just by having an arthrodesis. And it might not be really the best outcome measure to compare these groups because that's not really the point of the comparison. It's more to see how their lives are affected. And so if you were to eliminate that, then these scores of 80, 81, 82 look a whole lot better. And maybe these people are doing really well despite the motion.
What are those clips for on the outside of the ankle?
I'm sorry?
What are the clips on the outside of the ankle?
The staples.
Why are they in 3 months post-op?
This must have been immediately post-op. This person, for some reason, didn't have any final follow-up x-rays. I'm not sure why. This must have been the 2-week visit. Yeah.
Well, nothing destroys confidence like follow-up.
Going on to our last patient, this is the 49-year-old who fell from the attic with a very complex open wound, horribly controlled diabetes, and an extruded tibial plafond, which we had on the operative table with us. These were the initial x-rays. They also had the concomitant ipsilateral tibial plateau fracture. They were initially X-fixed and taken for the CT. Okay. So
that sounds like that's COVID there. That's the COVID cough.
You can include in tibial talar arthrodesis if you want to do antegrade and nail the whole thing.
There's no option for amputation.
No, sorry, that's not an option. All right, so we're getting a lot of TTC nails here. That's not what we did. The tibial plateau was treated with no RF, and the right ankle was IND'd, and a posterior plate and screw construct for a tibial talar arthrodesis, and iliac crest bone grafting. He's 49. This is what he looks like post-operatively. And then at 5 months, he was fully weight-bearing in a rocker bottom shoe. His fracture site and fusion site had consolidated. He had no pain, and all of his wounds were healed. I think really for this one, the primary reason for doing a plate and screw construct rather than the TTC nail is this prior injury that he had there. That's likely occluding his medullary canal. It would probably be very difficult to get a nail that forms to that medullary cavity. Luckily, this patient did well despite having the worst diabetes ever. Yeah. Yeah.
A long nail all the way.
All right, so that's all of our cases. To conclude here, I think based on what's available out there, primary arthrodesis can be a valuable option in a very complex fracture or patient, but it's definitely not right for everyone. And it's been extremely difficult to study because this is not the most common Pilon patient, although it does happen frequently. There's also a very heterogeneous group with a lot of additional complex injuries and other body parts and systems. Additional injuries are definitely likely to influence the outcome scores that are presented in these articles. And as we mentioned, the current outcome measures we have for the foot and ankle, most commonly being AOFAS, gives you -14 right off the bat for losing the motion in the tibial talar and subtalar joints, which make it difficult to compare apples to apples in these cases. I think really here there's a lot of really good opportunity for further investigations. I think it would be challenging at an institution like ours where we maybe see a few of these a year to get a high quality cohort study. But in some of these larger trauma centers where they have databases and registries of all their patients, I think that it would be relatively straightforward to do a comparison study between type C3 fractures that go on to primary fusion versus ORF to compare their outcomes. And I think that there's really a lot of opportunity here to get a lot of important data for our patients that really, at this point, if you're recommending a primary arthrodesis to a patient, it's still based almost entirely off your gestalt as a surgeon.
I think you would need like multi-centers. I even say this on interview day. I think we see a lot of Pilons, to tell you the truth. I don't know, Carlos is always pointing out that we do a lot of Pilons compared to maybe other trauma centers. And I'm not saying we do enough to ever perform a definitive study, but your review of the literature shows how challenging it is to come up with an evidence-based decision on how to manage these. And just like they did with open tibia fractures, it's really going to be required by the Trauma Society to put together a good multi-center trial to figure out how to do this.
Yeah, it's got to be with patients where they're following all these outcomes,
yeah,
because the majority of what's out there is just union rates and complications. And it's really not enough to base treatment off of.
Sure. Good job. That was a good talk on a very difficult topic. I mean, it's always hard when you end up thinking, well, still don't have a great answer for you. So yeah, pick your poison.
So hopefully everyone at least knows the options now. Thank you to Dr. Sahabian and Dr. Fleming for your help, and to all the patients who were included.